This lecture covers relevant pharmacotherapy for trauma cases. The lecture will review epidemiology, outcomes, assessments, necessary labs, and medical treatments. Then we will cover a more specific example of a trauma, such as a traumatic brain injury, as each trauma can have different treatments based on anatomical location. Lastly, we will review some RSI details. The objectives to accomplish via this lecture are to understand the causes and prevalence of traumas, to become familiar with treatments needed in the emergent setting of a trauma, as well as other therapies. This graphic lists the top 10 causes of deaths among various income groups. Road injuries, being the most common trauma, is listed as the 9th leading cause of death, with a higher prevalence in middle-income countries. Road traffic injuries are hugely common, involving 1.24 million deaths per year, with 3 of 4 of the deaths being male. It is the most common cause of death in the 15 to 29-year-old age group. These numbers are only expected to increase in the future. The most common causes of death in trauma are brain injury, exsanguination, which is bleeding out, and airway compromise. The proportion of traumas vary by country. However, motor vehicle accidents almost always take up the most significant portion of trauma accidents. As is expected, some patient characteristics lead towards worse outcomes in patients. Elderly age, obesity, major comorbidities, and warfarin usage dramatically decrease chances of positive outcomes in trauma patients. Although being brought to a properly designated trauma center with appropriately trained and experienced personnel improves morbidity and mortality rates. The 5 main goals of a pharmacist during the trauma resuscitation period are listed on this slide. To train a pharmacist to become better during trauma situations, obtaining Advanced Trauma Life Support Certification, or ATLS, may be beneficial. There are 2 phases in assessing trauma patients. The first, initial assessment, has the mnemonic device A, B, C, D, E, with A meaning airway, which primarily for the pharmacist means determining if you need to select and prepare agents for rapid sequence intubation. We will discuss this at the end of the lecture. The B is for breathing, where rate and depth must be evaluated. If a large hemothorax or tension pneumothorax is present, the patient may need a chest tube inserted, in which case the pharmacist ensures adequate analgesia is provided for the procedure. The C is circulation, which is largely referring to hemorrhagic shock and managing associated hypotension with 1 to 2 liters of normal saline or lactated ringers initially, and considering 1 to 2 types of O-negative blood after that, as well as other blood products mentioned in the blood products lecture. Vasopressors as a third-line agent can be utilized in this situation as well, including norepinephrine, dopamine, epinephrine, or phenylephrine. D is disability, where the pharmacist should weigh anti-epileptic treatment options as well as factors for hypoglycemia and alcohol use. E is environmental, where the pharmacist is mostly just concerned about temperature. After the initial evaluation, a secondary survey should be completed. This is where concerns such as tetanus immunization, antibiotic prophylaxis, anatomical site-specific treatments, and long-term analgesia and sedation should be evaluated. The Glasgow Coma Scale is a universally accepted tool for assessing cognitive status in patients. It is simple to use, has high reproducibility, and excellent predictive value for overall prognosis. Although it is limited by confounding factors such as medical sedation, paralysis, intubation, and intoxication, which can make the score seem lower than it really is. The common saying is, GCS less than 8, then you need to intubate. So, if you hear a patient is being brought in via ambulance and has a GCS score of less than 8, the pharmacist should begin preparing intubation medications. In regards to the ordering of labs, clinical circumstances determine which labs are needed. For example, if a patient is known to be on warfarin, then you would obtain a PT-INR value. Although not every single trauma patient necessarily needs a PT-INR lab drawn. Or a pregnancy test would only be for women of childbearing age and so forth. Some labs are almost universally drawn, particularly in severe traumas such as a CBC or complete blood count to gauge blood loss and need for transfusion, renal function to ensure safety of using contrast imaging, and also lactate is one lab that has evidence supporting its routine use in severe patients to assess end organ perfusion. Ordering lactate within 24 hours has been associated with a decrease in mortality. Imaging studies play an important role in traumas as well, including portable radiographs, ultrasounds, emergency CTs, and ECGs. Initial medical treatment always starts with treating the site of the hemorrhage and restoring blood volume. A bolus of crystalloid fluid, lactated ringers, or normal saline, 1 to 2 liters or 20 milliliters per kilogram is the first step. Due to the large amount of fluids sometimes required, warmed fluids are preferred to avoid hypothermia, which can decrease cardiac output. If the patient is still hemodynamically unstable, the next option is to infuse type O negative blood through a different line to decrease risk of clotting. Red blood cells are usually transfused with a 1:1:1 ratio of fresh frozen plasma and platelets. Tranexamic acid has also been shown to lower mortality rate versus placebo in severe traumas if given within 3 hours of injury. The next 2 slides show how blood loss in trauma is categorized. Based on amount of blood loss, different signs and symptoms will occur pending the severity. Heart rate and breathing rate are the first signs, with them being increased in response to decreased tissue oxygenation. Other signs and measures of blood loss are listed in this table. With more significant blood loss, heart rate and vasoconstriction can only compensate to a certain point. After about 30% blood loss, then the blood pressure will start to decrease dramatically, and signs of altered mental status will begin to appear. A recommended replacement rule for fluid is 3:1, which means that for every 100 milliliters of fluid lost, you should replace with 3 times that much. Packed red blood cells can be infused after infusion of crystalloid fluids and can be titrated if labs have returned quickly enough. Generally, packed red blood cells are given when the hemoglobin level falls below 8 or below 10 in patients with risk for acute coronary syndrome. Platelets also can be infused if a platelet count is obtained and is shown to be less than 50,000. If fibrinogen, an essential protein in blood clotting, is low, then cryoprecipitate may be administered. Prophylactic antibiotics need to be considered in some trauma cases including if the patient shows signs of infection, although not really prophylactic at that point. Such situations are when there is gross contamination or wounds with significant delay of many hours before presentation to the A&E. If they need to undergo surgery to fix damage from the trauma, or if they need to undergo abdominal exploration, or if they need to have a chest tube placed. The most commonly used prophylactic antibiotic is a one-time dose of cefazolin. However, antibiotic selection may be adjusted based on several factors or the local hospital antibiogram. For an intra-abdominal wound, enhanced coverage for anaerobes may be considered by using metronidazole, ampicillin sulbactam, piperacillin tazobactam, or even a carbapenem if risk factors for resistance are present. More broad-spectrum coverage may be considered in immunosuppressed hosts. For wounds involving water exposure, coverage for Aeromonas species with trimethoprim sulfamethoxazole or a fluoroquinolone can be considered. Thromboprophylaxis also needs to be utilized in many trauma patients. Risk factors for embolism in a trauma patient are shown here, and thromboprophylaxis should begin in the first 2 days following the injury. Tests or trauma embolism scoring system is sometimes used to gauge embolism risk. Pharmacologic VTE prophylaxis is more effective than mechanical prophylaxis. Low molecular weight heparin is preferred over unfractionated heparin unless the patient has significant renal dysfunction. Combining mechanical with pharmacological prophylaxis is the most effective method. There are many different VTE, PE risk scoring systems that can be utilized, including the Padua, Improve, or Geneva scores, all of which are fairly similar and one is not preferred over the other. Uncontrolled pain can also cause a more pronounced stress response, leading to an increase in the production and release of cytokines, inflammatory mediators, and catecholamines, which can alter blood pressure. Unfortunately, analgesia is often overlooked during a busy trauma resuscitation. A study has shown that only 38% of trauma resuscitation patients received analgesia in the A&E. Also, the average time from admission to the first dose of analgesia medication was 109 minutes. There is no gold standard in regard to door to analgesia time, but the vast majority of patients expect to be given a pain medication within 15 minutes of presentation to the A&E. This goal is very rarely reached. This is a huge area of improvement in which the pharmacist can have a significant impact. There are many reasons preventing the timely administration of analgesics. The primary concerns for physicians is the masking of symptoms of injury and possible adverse effects, including respiratory depression and hypotension. The other barrier to proper analgesia is the lack of priority among staff in an urgent situation, with many other concerns being addressed. Opioids are generally the agent of choice. The Society of Critical Care Medicine guidelines recommend the use of fentanyl as opposed to morphine, which is far more common in Hong Kong, due to its rapid onset of analgesia and minimal hemodynamic effects. Oral analgesics may be used for minor injuries but the onset is slower, so IV route may still be preferred. Stress ulcer prophylaxis also needs to be addressed in trauma patients. The American Society of Health System Pharmacists, ASHP, provides sound guidelines on which patients require stress ulcer prophylaxis. It can be important to start patients on the correct medications in the A&E department, as they may not be addressed for quite some time upon admission to the ICU. Tetanus vaccination should also be given to patients without a tetanus vaccine booster in the past 5 to 10 years. The CDC provides guidelines on when exactly tetanus should be administered. The most common cause of death from tetanus is respiratory failure. 5 to 10% of tetanus cases are fatal, with higher rates in the elderly. Glucocorticoids should only be utilized if other compelling indications are present. Trauma patients are hypermetabolic and have higher energy requirements, and if there is an abdominal wound, higher amounts of protein are lost. Enteral feeding is preferred over parenteral nutrition. Post-traumatic stress disorder, or PTSD, is also quite common in trauma patients. Trauma is the third leading cause of PTSD behind rape and death of a loved one. PTSD is characterized by intrusive thoughts, nightmares, flashbacks, and sleep disturbances. These then lead to social, occupational, and/or interpersonal dysfunction. There are several goals when it comes to PTSD, but the ones that medication therapy can help most with are irritability, anger, and depression. First-line pharmacotherapy of PTSD is the SSRIs. Agents with the most efficacy and their dose are shown on the table here. More often than not, pharmacotherapy is combined with cognitive behavioral therapy and counseling. These treatments should be continued for no less than 6 to 12 months. Alternative therapies include quetiapine and risperidone. Prazosin also has supporting data to be used as an adjunctive therapy that can decrease nightmares. Many other medications have been tried, such as benzodiazepines, antiepileptics, and ketamine. However, the risk versus benefit profile has shown that these agents are best avoided. There are many things to consider in the management of trauma patients. It is important to address them in stages based on their acuity. Hemodynamics, intubation preparation, and comfort are initially managed. Infectious concerns secondarily, then chronic management preparation lastly. Next, I would like to discuss a specific trauma, as besides all the general trauma measures mentioned so far, individual injury sites require different management. Traumatic brain injuries are more common in men than women, and incidence peaks at different ages for different reasons. However, only 3% of traumatic brain injuries are fatal, and 19% require inpatient hospital admission. These are also more common in individuals of lower socioeconomic status. Traumatic brain injuries require extra management, primarily possible seizure prophylaxis and intracranial pressure management. 6 to 30% of traumatic brain injuries, or TBIs, experience seizures. 25% of seizures are in the first hour and 50% are in the first day. Epilepsy prophylaxis is only beneficial for reducing early onset seizures, defined as within the first 7 days. Phenytoin and levetiracetam are the preferred agents and are less sedating. Intracranial pressure is the other major aspect that needs to be managed in TBI. Severe TBI patients with a GCS score less than 8 or equal to 8 should have their ICP monitored. CT scan is also useful in these patients to determine if ICP monitoring is required. The coronary perfusion pressure, or CPP, should be kept between 50 to 70, or an ICP should be kept at less than 20. These goals of proper perfusion to the brain can be met by either lowering the ICP, which is preferred, or by increasing blood pressure. Several non-pharmacologic options are available, including elevation of the bed by 30 degrees, monitoring of CVP, and avoidance of hypovolemia. When the ICP is greater than 20 millimeters of mercury, CSF fluid should be removed, usually from the lateral ventricle via catheter inserted through a hole in the skull. Alternative treatments are available, primarily osmotic therapy with hypertonic saline or mannitol. Hyperventilation is generally not recommended. Sedating the patient into a barbiturate coma, hypothermia, and decompressive craniotomy are high-risk last-line options. First-line pharmacotherapy is to provide the patient with sedation and analgesia to reduce metabolic demand and sympathetic responses of hypertension and tachycardia from the stress. Propofol is commonly used in this situation, but potentially fatal propofol infusion syndrome may occur. It is characterized by severe metabolic acidosis, rhabdomyolysis, hyperkalemia, renal failure, and cardiovascular collapse. As a result, it is suggested that when used in TBI, the infusion rate of propofol not exceed 4 milligrams per kilogram per hour, and that patients be monitored for ECG changes, lactic acidosis, and elevations in creatinine kinase and myoglobin. Propofol has additional concerns of decreasing blood pressure, and it is in a lipid formulation which comes with infection risk and requires changing of the bottle at least every 12 hours. The other primary pharmacotherapy option is osmotic therapy, using an osmolar gradient to draw water across the blood-brain barrier. This decrease in volume leads to a decrease in ICP. The two options are mannitol or hypertonic saline. Both are effective at removing fluid from the CNS. As shown here, trauma management varies significantly based on the type of injury, as some of these treatments wouldn't be relevant for, say, a thoracic injury. For the last part of this lecture, I want to briefly explain more about pharmacists' role in rapid sequence intubation. This is a layout of what I will cover in this section. These are the objectives, primarily focusing on appropriate drug selection. The 7 P's of RSI are listed here: pre-treatment, paralysis with induction, and post-intubation management are the areas where pharmacists have the most impact. Trauma and burns are the second most common reason for a patient needing to be intubated for mechanical ventilation. The other reasons are shown here. RSI happens very quickly. An ideal time window is shown here, with time 0 being when the physician will begin to insert the tube down the trachea and the paralytic medication starts working. The sedative should be given 30 to 60 seconds prior to the insertion of the tube by the physician and should always be given prior to the paralytic. Intubation is not a pleasant experience for the patient. It is a stimuli resulting in bronchospasm, increases in heart rate and intracranial pressure, as well as other physiologic responses. Despite these negative effects, we will still perform RSI for the goal of optimal control of the airway, to decrease the risk of aspiration, and because it comes with minimal complications and a very high success rate. Prior to intubation, patients are pre-oxygenated to ensure they are fully loaded on oxygen before starting the procedure, to provide the practitioner with as much time as possible to complete the procedure before the patient desaturates rapidly. Despite how not visually appealing this slide is, it does provide a lot of useful information. The bottom x-axis is the time in minutes and the y-axis is oxygen saturation. As you can see, different age groups and body sizes have different times until their oxygen saturation declines rapidly. Healthy adults provide the longest time until desaturation, and obese adults or children will desaturate the fastest. So a tube insertion procedure should be done quicker, if possible, in these patients. Next, I will briefly talk about pre-treatment options prior to intubation. The purpose of using medications for pre-treatment is to attenuate or minimize the stressful pathophysiologic response to the intubation and medications used for induction. On average, during an intubation, a patient's heart rate increases by about 30 beats per minute and mean arterial pressure increases by about 20 to 25 millimeters of mercury. These pre-treatments are considered in ABC's patients: patients with asthma, traumatic brain injuries, pediatrics, or patients with cardiovascular complications. The mnemonic for pre-treatment meds is LOAD. Lidocaine starts working within a minute and lasts for about 10 to 20 minutes. It is not routinely used, but may be used in a TBI patient or suspected elevated ICP patients or patients with asthma to prevent bronchospasm. It works by numbing the airway, which can minimize ICP elevation from the laryngoscopy. It can also suppress cough and reduce sympathetic response. The O is for opioids such as morphine or fentanyl, and is generally used for the same reason as lidocaine, which is to reduce sympathetic stimulation in patients with a possibly elevated ICP, major vessel disease or dissection, or increased heart rate and blood pressure. Lastly, atropine may be used to decrease the bradycardia side effect from succinylcholine. This is primarily for pediatrics less than 1 year old, pregnant patients, patients with age less than 5 and receiving succinylcholine, or those who have to receive 2 doses of succinylcholine, or those with airway disease such as asthma. Defasciculation is a small dose of rocuronium to prevent muscle contraction, myalgias, and an increase in intragastric pressure from succinylcholine. This is not commonly done, and we will not discuss any further in this lecture. Next, we will discuss the sedative options. There are many options available, and the convenient part about it is that none of the medications require renal dose adjustments, and the dosing is the same for pediatrics and adults. The drugs are all generically available and used universally no matter which country you practice in. As all these medications are weight-based, it is important to have an accurate weight for the patient. However, many RSI patients are not able to tell you their weight, and that is when a Broslow tape should be utilized to help estimate the patient's weight. It has been shown to be far more accurate than nurse or physician estimation. Etomidate is generally the sedative of choice due to its fast onset, short duration, and favorable side effect profile. However, it should be avoided in septic shock in pediatric patients. There is a small risk of emesis and high risk of injection site irritation with etomidate. Injection site irritation is usually the least of a trauma patient's worries. The vast majority of patients who are given etomidate will see a transient decrease in cortisol levels. The adrenocortical suppression raises the concern of having lower cortisol levels in shock patients, possibly decreasing positive outcomes. However, no significant difference in shock patients requiring intubation has been seen in patients who received etomidate versus ketamine in regards to mortality, organ failure, hospital or ICU length of stay. Ketamine is the first alternative and is considered the drug of choice in patients with septic shock or hypotensive patients due to its ability to increase blood pressure, whereas the other induction agents are either neutral or have blood pressure lowering profiles. It may also be useful in asthma patients as ketamine causes bronchodilation. Ketamine has many properties, including analgesic properties, anesthetic properties, and may cause amnesia, which can be helpful for a patient to forget this unpleasant experience. Ketamine has several adverse effects that are important to note. Reemergence phenomenon is one unique adverse effect where the patient has very vivid and realistic hallucinations from the medication. Sometimes this experience is pleasant, but often it is an unpleasant experience, especially in adults. This poor reemergence delirium experience can be minimized or eliminated by using benzodiazepines for maintenance sedation. Much like with etomidate, emesis may also occur, particularly in children around 9 years old. Rarely, arrhythmias may also occur from the tachycardia associated with catecholamine release from ketamine. There is increased salivary production, which minimally makes the intubation procedure slightly more difficult, and the medication is contraindicated in patients with schizophrenia or schizoaffective disorder. Midazolam is the benzodiazepine of choice as it has the fastest onset of action. Propofol is another alternative that can be used as induction and maintenance sedation. They both have amnesia properties and anticonvulsant properties as well. They both cause lowering of blood pressure and mean arterial pressure, which can be problematic in shock or hypotensive patients. Lastly, thiopental and methotrexate are sedatives you will rarely ever see, so I will not go over them in this lecture. This table provides a summary of desirable drug properties for the sedation agents as a summary to help you review. This table provides a summary of the sedatives of choice based on patient-specific factors. As you can see, etomidate and ketamine are the most commonly listed agents. Next, we will discuss the two options for paralysis, succinylcholine and rocuronium. Addition of a paralytic agent to sedation dramatically increases favorable intubation conditions, making it far easier for the practitioner. Succinylcholine is the drug of choice for RSI paralysis due to its quick onset and short duration of action. The main problem with succinylcholine is its long list of contraindications warranting usage of rocuronium instead of succinylcholine. Contraindications include issues with high potassium or disease states that result in elevated potassium levels, as shown here in the table. Also, malignant hyperthermia is a contraindication. It is important to note that it can be okay to use succinylcholine immediately after some types of injuries, as potassium elevation is not observed until 2 or more days after the injury. Succinylcholine is a depolarizing neuromuscular blocking agent, or NMBA, whereas there are several non-depolarizing neuromuscular blocking agents. A depolarizing NMBA means that it initially activates the muscle fiber, but then makes it so that it is not responsive to acetylcholine anymore. Whereas the non-depolarizing agents simply just block the activity without the initial contraction. Rocuronium is the preferred non-depolarizing agent, again due to its fastest onset and shortest duration. Rocuronium may be considered over succinylcholine when the patient has risk for an elevated ICP, renal or hepatic failure, or contraindications to succinylcholine. It has minimal effects on hemodynamics. In neonates and infants, the onset and duration is more unpredictable and unfavorable. Neostigmine is a drug that can somewhat reverse the paralytics. This graphic is to show you the differences in duration between the top 4 sedatives and the 2 paralytics. This is important because a patient should never be paralyzed and not sedated. Being paralyzed and having pain from trauma while not being sedated is essentially torture. As you can see, several of our sedatives last shorter than our paralytics. So it is important, especially when using rocuronium, to use follow-up doses of sedatives or begin maintenance sedation quickly. Post-intubation management and the pharmacist's role. An emergency pharmacist should have knowledge of how long the drugs last. You should never leave the patient's bedside until maintenance, sedation, and analgesia are being provided. Maintenance, sedation, and analgesia agents differ somewhat than the agents used for induction. In the maintenance phase, paralysis is optional and is usually not added in the A&E and reserved for decision by the ICU team. The pharmacist's primary role in RSI is to focus on drug selection, dosing, and contraindications, as the physicians have so many other tasks to be focusing on. These 2 slides are just a list of questions to ask prior to intubation and after intubation to ensure you make appropriate recommendations based on what information is available at that moment. This is a list of responsibilities of the pharmacist during a trauma resuscitation, which is quite broad and encompasses many things which highlight the importance of having a pharmacist around during trauma resuscitation. 3 key concepts worth repeating include: 1. Pre-treatment medications can be considered. 2. Induction and paralytic agent selection should be based on pre-existing conditions and current medical status. And 3. It is important for clinical pharmacists to work closely with physicians and nurses in selecting appropriate agents for RSI and managing immediate post-intubation care. These are the references used for this lecture, and that concludes this section of the A&E module.